let's talk about prostate gland disorders. Okay, something pretty common for prostate gland disorders is prostatitis. Prostatitis is just an inflamed prostate, but it could be caused by multiple different things: trauma, bacterial infections, also a recurrent or at least a recent urinary tract infection. We see this a lot in older patients, but don't get confused. It does happen in younger patients when we have trauma or bacterial infections. But recent urinary tract infection, it can, if there's like a bladder infection, a urinary bladder infection, it could then descend towards the prostate, right? Signs and symptoms, they get fevers, chills, pelvic pain. They may also get dyspareunia, okay, which is pain during sex, intercourse, okay? They do get a pain also with ejaculation because the prostate gland is doing its secretions, and it's inflamed, it's going to cause some sort of pain. You're also going to get a slew of different urinary tract signs and symptoms: dysuria, burning when you pee, frequency, the idea that you're going, you need to go to the bathroom quite a bit. Nocturia, again, nocturia is voluntarily needing to go to the bathroom throughout the night. So you're holding it in, you're just consciously aware that you need to go to the bathroom, not that you wake up and the bed is already wet, right? That's enuresis, though. So we're talking about nocturia. Pyuria, if there's some sort of pus in the urine, and hematuria can also occur with blood in the urine. Usually you will have an enlarged tender prostate. And this, again, is done by palpation by the doctor doing a rectal exam, which I'll show you in a moment what that's all about. Okay? So this is pretty common. It's pretty easy to cure also. You know, if it's bacterial infections or some kind of infection, you're probably going to give them antibiotics for something like that. All right? So, but it can cause severe pain. Again, you don't get all these different things. You may, but it may, you know, if someone has nocturia and dysuria, don't always think that it's a urinary tract infection. It can be prostatitis, obviously in a man, okay? All right. We can talk about benign things and malignant things. That's basically what we got to do with the prostate. So we have something called benign prostatic hyperplasia. Now keep in mind what hyperplasia is, not hypertrophy. Hyperplasia is that we're going to increase the number of cells, but not the size of the cells. Hypertrophy would increase the cell size, but not the cell number. And a good example of hypertrophy is muscle cells, right? When you're lifting up muscles, your muscles get big. You're not putting more cells there, you're making the cells get bigger. That's muscle hypertrophy. When we're talking about this, BPH is benign prostatic hyperplasia. Okay? This is just something that us guys just have to look forward to. It's just going to grow to a normal size, or to get to a bigger size, but it's not something to worry about. We need to decipher that if the prostate enlarges, is it because of a benign reason, this, and it'll cause some problems, blockages and stuff, but it's not going to spread. But we need to make sure it's not the malignant form, which is what we are more concerned about, which is the number 3 killer of cancers in men, right? So basically what's happening with benign prostatic hyperplasia is that you'll get this enlargement, gradual enlargement of the prostate. And like I said, it's appropriate in our normal aging process, okay, for us to do this. 20% of 40-year-olds will have this, 90% of 70-year-olds will have this. It's just something that we look forward to, so to say, okay? Our problem is that it can compress on the urethra. So we have so this is your urinary bladder. Here's your urethra. We could have the prostate over here. We're going to have a thin piece of muscle over here. And then you're going to have the penis itself. Okay? So urinary bladder, the prostate gland, a muscular layer, and then the penis itself. So the length of the urethra is not the length of the penis. So when I say the length of the urethra is 7 to 8 inches, that doesn't mean the penis is 7 to 8 inches. All right? But since we're talking about this, what is the average length of a penis? 5.5 inches. Okay? But we have another 2 to 3 inches that is found inside the body. That's what you have to think here. The prostate is here. So what I'm saying here, prostate gland, benign prostatic hyperplasia, is that what will happen is this prostate will enlarge. But it can also enlarge not just that way, but it enlarges this way too. And when it does, it's going to block urine from going full strength out there. And in a case like this, the patient usually says that when he goes, he feels like he has to go really bad, but it only dribbles out. That's because the pressure here is not strong enough to get the urine through this little tight opening. It's stenosed, right? And then what comes out is like dribbling. It comes out dribbling. Okay? So usually about 50% of people who have BPH, it's usually asymptomatic. All right? Frequency does happen, but in small amounts. So they have what we call nocturia. They're consciously alert that they have to go to the bathroom 3 to 4 times throughout the night. And when they do, a small amount comes out, or it just dribbles out. Okay? They have this weak stream. All right? So questions about that? All right? If it's so bad, then we just go in and we'll remove the prostate. So they have no problems with the urine. Okay? So this is where it can happen. I kind of showed you that it can be pressing against it. We'll talk about prostatic cancer in a moment. So that's what this is going. It can cause that. Now, prostatic cancer can do the same thing too. Depends on where this is all happening. I mean, this BPH can happen over here, and you might not have the symptoms of the dribbling. It depends on where it is. Okay? All right, so now let's talk about prostatic carcinoma, prostate cancer. Okay? This is the #1 cancer found in men, the #2 cause of cancer deaths in men. Okay? 70% of men who are over 70 years old will have this. Right? More blacks than whites have this, and there's a strong genetic predominance with family history. If dad had prostatic cancer, you're at risk of having it yourself. All right? It's a slow-growing cancer, and that's why it's important to get this checked at least once a year so we can catch it early and get rid of it. The diagnostics is a digital rectal exam. When the doctor does this, he inserts his finger into the rectum, and the doctor is able to, I'll show you a picture, is able to feel the prostate. The prostate is about the size of a walnut, and it has the consistency of your nose. Okay, there's 3 consistencies that you should know about, that you could actually talk to other medical professionals about. You have this consistency of the tip of your nose, this consistency of softness of your lip, and then there's hardness like your chin. When you feel something hard like your chin, that's like the prostate itself. You're thinking like cancer, something hard like that. Okay, soft you wouldn't expect that to be on there unless it's very fragile, but it should be at the consistency of your nose. And that helps. When I talked about fruits and about the size of the uterus to you when I did the female anatomy, sometimes it's easier to explain that to other medical professionals and to laymen for that matter, so they could relate to what you're feeling. Sometimes it's difficult to explain what you actually palpated. Okay? So we suspect that when they check the prostate that there is no hard or nodule areas like your chin. all right? That there is no asymmetrical mass, that you don't feel like a mass on one side, then you feel nothing on the other side. You got to suspect some kind of prostate cancer might be happening over here, okay? So that's what's happening. We also can do a blood test, a PSA, a prostate-specific antigen test. It's a blood test, and elevation of it will indicate if there's BPH versus cancer. All right, so it's a protein that comes from the prostate. Okay. So doing a digital rectal exam, just so you can understand, you got to understand anatomy for you to really appreciate this. So here's the prostate, here's the urinary bladder, here's the prostate, and here's leading to the penis itself. So if they do a rectal exam, they can actually feel the prostate. But do keep in mind, you're only feeling, I'm thinking like about 180 degrees of it. You're not going to feel the anterior side of the prostate. Does that make sense? You can only feel the posterior aspect of the prostate. So if there's cancer that happens on the anterior side, you can't feel that unless it's actually going, full stream to the back here and you feel something hard. So prostate exam is good, but it's not picking up everything. You also got to do a PSA on that, right? It's a blood test. Ambiguous genitalia. Let's talk about this. Interesting stuff. Interesting stuff. So we have something called homologs. I talked to you about before. Up until about 5 weeks of gestation, you can't differentiate if that embryo is male or female. In fact, it will look more female than male. So something happens at 5 weeks. Okay, but up until 5 weeks, the general features look the same, okay? But keep in mind, a male is XY. So yes, there's another hormone involved here. A male is XY. If they're XY, they have another hormone called molinary inhibiting hormone, or something called anti-molinary hormone. Now, men and women, or female and male embryos, have what we call molinary ducts. If the molinary ducts are left to be, they will grow into female features. There is something called Wolffian ducts, and I kind of just remember Wolffian meaning male. They do, both male and female have Wolffian ducts, but the Wolffian ducts won't form unless the molinary ducts are not forming. Does that make sense? Okay. The default is molinary ducts forming, making female. But if the molinary ducts don't form because you have this hormone, then the Wolffian ducts will overcome that and they will form male features. So think of Wolfman. The Wolffian ducts make male features, molinarian ducts make female features. But if you have an XY, you have another hormone, anti-molinary hormone, that will inhibit the molinary ducts from forming, so you're not going to get female features, but allows the Wolffian ducts then to grow, and now you get male features. Okay? If you are female, an XX embryo, then they don't have this anti-molinary hormone, so the molinary ducts will continue to form, allowing the Wolffian ducts not to form at all. Does that make sense? Okay, so that's what happens with that. Okay, and the molinary ducts will then form into female features. So this is just showing you this whole thing. If you're an XY, you have testes, you have the serotoli and Leydig cells. The Leydig cells will make testosterone. Serotoli cells will make anti-molinary hormone. That will then not make the molinary ducts form, allowing the Wolffian ducts to grow into male features. If you're XX, with ovaries, there is no anti-molinary hormone, and then therefore your molinary ducts will be allowed to continue to grow, and the Wolffian ducts won't grow at all. because the molinary ducts are the default, okay? They're dominating. Okay, so here's some interesting stuff, okay? So this is what the fetus looks like up until 5 weeks. And if you take a fast look at this, it looks more female than male, does it not? Right? So you have the two gonads over here. Now the red area is going to be our Wolffian ducts. The blue tubes are going to be the molinary ducts. So here's what happens. They'll still both be there, but the molinary ducts take priority. If the molinary ducts are allowed to grow, meaning like there is no anti-molinary hormone, then the blue is then going to form female features, and you've got your female anatomy. If you're XY, that means you also have anti-molinary hormone, and that's going to destroy or inhibit the molinary tubes, so the blue won't form, but allows the Wolffian ducts to continue to grow, because it kind of pushed off the molinary ducts. So now you're going to get male internal organs forming, because the Wolffian ducts are allowed to grow. Okay? Questions on that? All right, now that's the internal genitalia. What does the external look like? Same way here. Here is up until 5 weeks. We can't, gestation, we can't tell if it's male or female. But there's different parts over here depending on if we have the molinary ducts or not. All right, if there's XY versus XX. You can follow it. For instance, see the yellow area there? It's called the glans area. When that continues to grow in a male, that glans area becomes the head of the penis, the glans of the penis. But homologous-wise, in a female, that glans area becomes the glans of the clitoris. So the glands of the penis and the glands of the clitoris are made from the same area. They're the most sensitive spots on the penis, the most sensitive spot on the clitoris. It makes sense. Also, too, the purplish area over here, that becomes the scrotal sac. In a female, the labial-scrotal swelling becomes the labia majora on the female. They're analogous with each other, or homologous with each other, right? We also have this reddish area over here. In males, they will fuse together so there's no opening there. In fact, if you look at the ventral portion of a male's penis, you will see that there's a scarred area there. That's where that actually fused together. And in certain people, that doesn't fuse and it stays left open. We got to fix that, right? In certain males, right? In females, this doesn't fuse, but instead it becomes the labia minora and stays open. Okay, so does that make sense? This is an interesting thing over here. I bet you some of you want to like print this out and put it on your fireplace mantle. It's a good conversation piece. But it's an interesting thing so that you actually see how females and males evolve, at least embryologically. Okay. Now, what if things go wrong? we could have ambiguous genitalia. External genitalia is just unclear. Is it a male? Is it a female? We can't tell when the baby's born. It's not clear. So we say it's ambiguous, right? This isn't a medical term. Ambiguous just means we're unsure. We're unclear of what's going on. Now, this is where hermaphrodites get in. There's something called a true hermaphrodite, and a true hermaphrodite contains testicular and ovarian tissue. Now, this is extremely rare. I've never even saw a case about this. I only heard about it and reading it in the textbook. All right, it's very rare that they have testicular and ovarian tissue. We have something called a pseudohermaphrodite. This is a little bit more common. This is where it contains testicular or ovarian tissue. But the external genitalia is ambiguous. Okay, so let me give you an example or some pictures here. See over here, small penis, or is it an enlarged clitoris? Right? Is this a micropenis, or is this clitomegaly? In other words, an enlarged clitoris? We don't know. We're going to have to do a chromosome study to see if it's XX or XY. Does that make sense? Because there's ambiguous genitalia that's happening. All right? So that's where that comes in. All right? And I've delivered probably about 3,000-4,000 babies. Maybe 3 babies I had like this. Okay? So it's rare, but it does happen. All right. Now we have something called testicular feminization. What is all this about? Okay. It's also referred to as testosterone insensitivity. For some reason, the testosterone is just not working on the receptors. So what happens here is a person is XY, so they're male. But for some reason, the receptors of the testosterone are not working. This is a very interesting thing. And this is more common than we think. What happens here is you have all this testosterone that is building up this person, but it has no place to go. It doesn't have receptors. So now your testosterone in your bloodstream is building up and building up. So they're making cholesterol. So your body has to break down the testosterone. To get it out of the body, it has to turn it back into cholesterol. And then your liver takes care of that, breaks it down, puts it into bile salts, or whatever it needs to do. Okay? Maybe make more other hormones and whatnot, steroid hormones. So we got to break it down to cholesterol. But in the process, now you have to keep in mind, males have testosterone receptors, all of us, all males have testosterone receptors and estrogen receptors. It's just we don't have much estrogen in our bodies, but we do have estrogen receptors and some estrogen goes there. Likewise, women have estrogen receptors and they have testosterone receptors. Okay? So both males and females do make estrogen and progesterone. I'm sorry, estrogen and testosterone. Well, this is what happens in a person who's got testicular insensitivity. They have a lot of testosterone, but they don't have receptors that work for the testosterone. So they're insensitive. So testosterone is insensitive to the receptors. That's how they get its name. So now the testosterone, no place to go, builds up and builds up and builds up. The liver is going to take all this testosterone, try to break it down. But in the process of breaking it down to cholesterol, it has an intermediate. It changes into estrogen, and then it'll change into cholesterol. Here's where the problem is. When it builds up and becomes estrogen, before it turns into cholesterol, all the receptors for estrogen turn on. Because if all this estrogen that was converted from all this testosterone, and before it gets to cholesterol, it's now going to go to all the receptors of estrogen, which means it's going to turn on all the estrogen receptors. You've got a whole bolus of it. In fact, there's more estrogen in these people, right, in these people with testicular feminization, than even normal females. And they're turning on all the receptors. Okay? So the testosterone has no effect on the body. Since the testosterone has nowhere to go, it gets converted to estrogen by something called aromatase, right, found in adipose tissue, all right, before it goes to the liver to become cholesterol. Okay? This buildup of estrogen occurs and easily saturates all the unused estrogen receptors, all right, and turns them on. What happens here is that they become more, I gotta say this without being risque, they have more female features than normal females do. Does that make sense? Because all the estrogen receptors are turned on. The breasts get shaped more, because all that are turned on. The adipose tissue grows in certain ways to create more of a voluptuous body, so to say, right? Because that's what creates the adipose. That's what creates the, like for models, the fat is being distributed in a certain way in that person, and that's why they're models, so to say. Or again, that curves what's happening there. So what happens here is that highly probable examples. Do you guys know who Jamie Lee Curtis is? She's I don't know if I got a picture of her, but she is, she had famous parents. I think her mother was, we watched the original Psycho, the one in the shower, that, you know, that thing. Lee, I forgot her last first name, but anyway, she was the mother, and then Tony Curtis, who was in a few movies in the 60s, a famous actor, her father was there. But her herself, she was in the original Halloween movie, and then they remade one, I think a year or two ago. She was in it again. She also is a spokesman for Activia, right, the yogurt over there. So anyway, but she's female, but the thing is, and I don't want to get in trouble with this, I'm just saying I learned from credible sources, from the president of the American Diabetes Association. Usually endocrine people would know more about this, but I got it from credible sources, so I don't know if it's true or not, but listen to high people. They believe that she has testicular feminization. Now, what happens with something like this is, I guess, not just with her, but for even probably with a lot of female models, these supermodels and stuff, because they're so, like I said, they look more female than normal female. It's just, again, I'm trying to say that without being so, being too, well, you know what I'm saying. I want to be too risque with it, but I think you understand what I'm saying. They just have more female features, or they're more prominent, I guess is a better word. So what happens here with female models is, and with Jamie Lee Curtis, when the baby comes out and it looks more female than male, then they assume that the person is female. I'm not going to do a pelvic exam on it. There's no reason to. It looks more female. Like I said, the clitoris looks very small, or it's ambiguous, but it looks more of the female. Maybe it's just because of the way the genes are that it looks big. So now the first sign might be when she's supposed to have a period and she doesn't. Does that make sense? Now she's 16 years old. She's never had a period. They go see the doctor. They do more tests and realize that she's a male, for that matter. So, so the question is, you know, it's usually a shocker to the whole family. How do you want to raise this person? Because she's really an XY. She's really male, but she's been treated as though she's female or like up until 16. Usually they'll just say, let's just continue with her, besides doing a psychological evaluation and all that kind of stuff, but medically and just, you know, organically, they'll tend to say, let's keep her as a female. Why change things? And they got to rearrange certain things anatomy. They can make a pouch over there so that she could have sexual intercourse, but the pouch would go no place. There's no uterus there. Does that make sense? So she could enjoy sexual intercourse with her mate later on in life, but she wouldn't have any children for that matter, because she doesn't have a uterus for that matter. And they've also done it so well that they put nerves and sensations in the vagina that they could, I guess the vagina itself goes through an orgasm, and that's what they, so they get some satisfaction with that. So that's probably what happened with Jamie Lee Curtis. A lot of female models, now think about this. The female models, they don't want to get pregnant. They usually start off their, not usually, but I guess a lot of them start off in their modeling stages in an early childhood, maybe, when they're 8 years old, they'll probably go through a lot of pageants, or maybe when they're teens. So they have to eat a certain amount, they have to exercise, so they can't build up a lot of weight to be those supermodels and stuff. So they don't know anything about what they have, but because they're not eating right, because they're exercising, these are all reasons why they might be amenorrheic. In other words, why they might not have a period, and they might just owe it up to that. And then when they're 21 years old, they still haven't had a period, but they just said, well, it's probably because the way I was eating, I don't eat that, that much. I eat like a bird, like eat very little, do a lot of exercise, and that could be the reason why I didn't have a period. But then she's, let's say 30 years old, and now she doesn't want to be a model anymore, or maybe she wants to have a child and realize that, she's been trying for the past year with her partner and she can't get pregnant. So she sees a doctor, they do some tests, and realize, lo and behold, you're an ex-wife. So we got a couple of problems here. One, she isn't going to get pregnant, obviously. Two, where's the testicles? Because she does have testicles. They're up here. They never descended. So now we have to remove them. Why? Not because of infertility. She isn't going to get pregnant, but because they could become cancerous. Does that make sense? So, she won't ever be pregnant for a couple reasons. All right. So this is just, again, I'm not saying all models are like that. This is just something that, like I said, these are highly probable examples of what's happening with that. All right. This gives you some idea. It's very interesting about testicular feminization. Okay. And this is just showing you where there's a buildup of testosterone, right? Testosterone becomes estrogen, right? Just showing that. You don't have to worry about the steps. They're just kind of showing you where that is.